Hello, everyone, and welcome. We've got a few hundred folks who are registered. Well, got just a little over 115 folks in the roundtable discussion so far. So we're going to give a few minutes for people to come in. We have a great agenda today, getting an update on healthcare and where it is today and where we're going from some incredible experts, not only in the healthcare field, but also in the emergency management field that has been dealing with this current crisis. So please stay tuned, stay tight. Good afternoon. As we welcome some more of our guests, I'm Alfred Sanchez. I'm the president and CEO of the Greater Miami Chamber of Commerce. I want to welcome everybody. We've got a great panel of experts who are going to be talking about the current coronavirus crisis, where we are in healthcare and where we're going. We've got some hundred or so members left to come on who registered. So I want to give them a couple of minutes more. Hang tight with us. We've got a great show. All right, well, I think we're going to get started. It's about 1:05 right now. I'm Alfred Sanchez. I'm the president of the Greater Miami Chamber, and I'm glad to welcome you to the first of our chamber roundtable discussions, which we will be holding every Thursday at 1 o'clock here at the Greater Miami Chamber channel. Hope you'll all tune in. We're going to hear from a variety of speakers today, as I've been saying, who are going to be looking at healthcare today in light of the coronavirus epidemic and where we are. And now that I think we're all starting to get used to how things are, where we're going, how we're going to get back to whatever the new normal may be. So we've got some experts from the hospital system, from the university system, from the emergency management system, all of whom are playing a key role in responding. Now, before we get started, I just want to go over some stuff. I know we're all pro-Zoomers now, but I do want to make sure that we have a valuable discussion that leaves time for your questions at the end. In order to run that efficiently, what I want to do is make sure that we're all following the same ground rules. The first is, at the end of the session, we're going to have all of the speakers to speak and do the presentations. If you have questions, please go to the Q&A section at the bottom tab of your control bar and raise your hand, submit your question in writing. After the presentations, we will have a question and answer period, and our folks who are working behind the scenes will gather questions and float them up to us on the panel. There are many more questions, I'm sure, than we have time. So folks will be working behind the scenes to answer some of them on the chat and on the question and answer. So look for answers there as well. Okay, so we have a lot to go over. Let me first give the mic over to our presenting sponsor from the Dade County Medical Association, the president, Antonio Mesa. Doctor, if you would want to say a few words.
Am I unmuted now? I should be. Okay. So thank you all for coming. This has been a very trying time for us, obviously. And I'd like to take a moment to recognize the sacrifices of physicians who've really been very resolute in not leaving their posts. I mean, even today, I am here in my own office because we are taking care of patients, trying to keep them out of the emergency rooms, trying to keep them from being exposed to a variety of pathogens, not just the coronavirus. And that is an important part of the healthcare system that the Dade County Medical Association has been supporting. I just wanted to note that we've had over 220 separate orders for personal protective equipment. We've filled over 15,000 items of personal protective equipment, including supplying some of the local hospitals, because it has been such a challenge. And we're continuing to support our physicians with webinars on telehealth and cares and Families First. We, like you, are in addition to being physicians and taking care of patients, we're also small business people, unless you happen to be employed. And in that case, you have a different set of problems. And, you know, that makes what we're doing here of interest to all of us. My office number, in case you need it, is 305-670-7650. And I'm always available through there. Thank you.
Thank you, Doctor. And you know, Doctor, if you wouldn't mind putting that number on the chat, so if folks are interested in calling, or even if there's a website you can direct them to, feel free to do that.
Okay, I will.
Great, thank you. So let me begin with our first panelist. Matthew Pinzer is VP and Chief Marketing Officer at Jackson Health System. He's a veteran communicator, a strategist, public analyst, and he's a team leader. He's also been the chair of many chamber committees. Most recently, he's the chair of the Chamber Health Committee, and has been a long time top leader of the board. So Matt, want to hear from you about what's going on at Jackson and U Health, and we're interested in hearing your perspective. Let me turn it over to you.
Thanks. Good morning, everybody. It has been an interesting time to be working in healthcare, that's for sure. My team and I like to say that right now we have the most difficult job in communication and the easiest job in healthcare. The situation at Jackson, I think, is pretty much where we expected it to be right now, which is to say there's a lot going on. We're very busy, and things are under control, and we have the capacity to be dealing with what the community is facing right now. So let me kind of speak to that in a few different ways. I think we've heard a lot. Obviously, the biggest concern is just how many people are infected, and even more to the point from a hospital perspective, how many people require hospitalization. When we talk about flattening the curve, it's funny because for almost everything happening in society, you don't want to flatten the curve. Almost everything, you want to have a huge spike in the curve, right? Because for your economy, for your social life, for everything else, you want to get it all out of the system as quickly as you can and then go back to normal. The reason you don't want to do that is the one place that can't tolerate that is the hospital system. So if you overtop the hospital system's capacity, whether it's in beds, whether it's in ventilators, whether it's in staff, then you end up with a huge number of potential deaths that are avoidable. So when we talk about flattening the curve, that's really what we're looking to do. And there's a lot of indication, very preliminary, but a lot of indication that it's working so far in our community. Maybe we started later than we should have, but when you look at the main metric that I'm looking at, and I literally get a report every hour, is the number of inpatients who we have who are either diagnosed positive or who are pending test results. And that number has absolutely gone up every single day, but it is going up at a pretty predictable and consistent number. So it's going up about 10 a day. Now, there is eventually going to be a point where that's not sustainable. But what's not happening, and what's very gratifying to not have happening, is it's not like it went up 5 the first day, and then 9 the next day, and then 16 the next day, and then 40 the day after that. It's that kind of curve spike that has really brought some of the New York hospitals, and certainly many of the hospitals in Italy, to the brink of disaster. I'm really grateful to be able to say that we have ample capacity in beds. We have ample capacity on ventilators. In fact, we're using, I just checked a few minutes ago, only about a third of the ventilators that we have in our system are in use right now, and only about a quarter of those, quarter to 30% of those, are being used by COVID patients. We have ample supplies of personal protective equipment. I know that's been an issue in some other cities, and I think on a day-by-day basis, hospitals have that issue. But from the outset, Jackson has always had what we needed to deal with the immediate demand and kind of the immediate foreseeable demand. And what we've really been focused on through our supply chain teams over the last 2 or 3 weeks is making sure that if this spikes even more than anybody is projecting for South Florida, that we don't end up in a position where we're short on that PPE. The other thing that has really been inspiring from my perspective, and having the luxury of working from home, but working pretty much around the clock the last month, is how the community has rallied behind its public hospital system, its academic medical center, in the big ways and in the small ways. We've had 3 or 4 different companies come to us and each donate 10 to 15,000 N95 respirators at a time where the challenge with them isn't being able to afford them. The challenge is just being able to find them in the supply chain. So one of the reasons that in the first week or 2 that this was becoming an issue in South Florida, that we didn't have to scramble so hard, is because we had our community showing up. We are now having more than 1,000 meals a day delivered to the Jackson hospitals by various restaurants and charities and community groups. And that is, as the head of our nurses union said, when you're in a situation like this, peanut butter on crackers looks like filet mignon. So when we're having some of the top restaurants in our market delivering, it makes a major, major difference. And the vast majority of these are coming through one charity, which has a fascinating business model. This was started by the chef Jose Andreas. They raise money from all over, and rather than directly giving that to the hospitals, what they do is they pay independent local restaurants so that the food suppliers still have business, the restaurant staff still has business, and then those meals get donated to the caregivers and the first responders. So something like that is really, really inspiring and empowering. Something else that we launched about a week ago now, I think time has become a flat circle for me. We are now doing twice a day at 9 a.m. and 9 p.m. We're doing 10-minute Zoom sessions for anyone on our staff who wants to go, 13,000 employees, which we're calling Pausing for Peace. And we had a really ambitious idea of how many different big name spiritual leaders can we get who would be willing to lend their time to just talk to our employees and give them a little bit of relief right now. Well, there wasn't anybody who we had to ask twice because people were asking how soon could they start doing it. Archbishop Wensky is doing it twice a week. Pastors from some of the largest churches in Miami are doing it. The imam of the largest mosque in Miami-Dade County, 2 of the rabbis from one of the largest synagogues, a Buddhist lama, a yoga teacher. And these sessions have just been really incredible, and we've had great response of employees signing on to it. So even though I think it has really tested us from a clinical perspective and certainly from a financial perspective, I think we're seeing the best of our community, and we're seeing the best of what we expect in a community health system like Jackson. I'd be remiss if I didn't say at least a little bit about the financial crisis that is very likely to be coming on the heels of the clinical crisis. Every hospital in the country has basically stopped doing elective procedures at this point. What that means for Jackson is about $25 million a month in revenue. Now, that would be a challenging thing for any hospital system to face. Private hospital systems in our community generally fall into one of 2 categories. There's a few exceptions, but most of them are either very, very well capitalized not-for-profit organizations that might have $1 billion, $1.5 billion in the bank, and this is going to be very hard for them, but they have the wherewithal to ride it out. Or they are for-profit hospital systems based usually out of state, which have other ways to stay capitalized during this. When you're looking at your publicly owned community health system, our surplus every year is somewhere in the neighborhood of, in a year, in a good year would be 15 or $20 million. So if we're looking at a revenue hit of $25 million a month until this gets resolved, this is not going to be the kind of thing where everybody can just kind of suck it up and bear it. And that's why one of the big messages that you're hearing our leadership team talk about this week is the need for Washington and Tallahassee to show leadership. The first financial aid bill that came out of Washington definitely covered things like how we are going to pay for the care of COVID positive patients, but it had almost nothing in there to talk about all of the lost revenue that for us to prepare for COVID by clearing out those beds, by getting rid of those elective procedures, by staffing up, by buying all of this extra supplies and equipment, there was nothing on that front. We are hearing encouraging signs out of Washington that things are starting to move on that front to give what we're calling a financial life support to the nation's hospitals. But if there's one thing I could leave this influential group of 200 people with, it's as you talk to your members of Congress, as you talk to folks from the Tallahassee delegation, they need to understand that this is not something where funding the cost of care is going to be nearly enough. If our community wants to come out of this in 30 or 60 or 90 days and even start moving back toward normalcy, we have to make sure that our health systems can stay open.
Thank you, Matt. I think you bring out some pretty incredible issues, and I think that we are all sort of looking at the virus and what's going on now. But you're right; there are long-term downstream implications that we need to start embracing now to deal with.
And I would also just ask everybody to keep in your thoughts the fact that every single one of us, whether you're working from home, whether you're still able to sometimes go to your office, whatever it is, I'm sure all of us have moments where we are scared, where we are anxious, where we are frustrated, where we are exhausted. Every one of our caregivers is feeling the same way, and that's not stopping them from showing up every single shift. These people are coming in just to one of the most frightening imaginable situations, and they're doing it with compassion, they're doing it with expertise, they're doing it in a way that should make us really, really proud to have one of the best public hospital systems in the country right here in Miami.
Absolutely. I think there's a reason why all those videos are going viral of every day throughout the world, communities coming out and celebrating and literally applauding the new superheroes in our time. Next up, we want to hear from Dr. Enid Roldan, who is the Chief Executive Officer at FIU's Healthcare Network. She wears many hats at FIU, including leading the clinical expertise that serves the Academic Health Center, FIU campus, and the community. And she has a storied 30-year career in healthcare, running Jackson Health System and as well as the Pan American Hospital. So, Dr. Roldan, let me turn it over to you.
Yes, good afternoon, everyone. As you can imagine, everyone has been impacted by this unprecedented times. At FIU, not only we have felt the impact on the clinical aspect, but we're also an educational institution. And with the educational, as you know, or you may not know, we do have campuses in China, and we do have a campus in Genoa, Italy. So when I speak of those two countries, you can only imagine that those were the two countries that got hit first. So we were working at this very, very early on, because as you know, China broke in December, but really it was January. So we got on the emergency, so-called emergency operations very early on, trying to bring our students from China, trying to bring our faculty, our staff. And so that was really the first impact. Together with also, that was Italy. We also have a very robust international travel of our students. So therefore, we already had students abroad that were that we needed to then make a decision to see if the students were going to come back. So when it comes to the impact of what coronavirus, COVID has done on FIU, it's been really three things. First, the education. Second, the clinic, and third, the services, because we also have vendors on campus. So very rapidly on March 16th, the entire university went remote. So all our classes, I would say, at a flick of a switch, we all had to go remote, and these were even classes that were not online. So there were two different types of classes. First, the class that were regularly online, but we then had those that were that basically were not online and now had to be remote. One of the greatest challenges that we had were the clinical, the medical school, the nursing school, the PA school. These are, these are educational programs that basically they need the hospitals and they need to be, that's part of their training program. So that has been a very interesting opportunity to see how best we can model and be best practices as we change the way that we're going to start delivering education. So this has been really an opportunity for us to look at the new normal, not only the new normal on the educational piece, but on the clinical piece. As far as the clinical piece, we had to also be able to adapt to a telehealth because of the fact that we wanted to mitigate the exposure of the virus. And we still needed to be able to be there for the emergency for our clinics. So we have maintained our clinics completely operational. And then those patients that do not feel comfortable coming to the clinic are basically being served through a telehealth model. Most recently, we, as you know, we opened up the FIU testing site that was open yesterday. This is a collaboration with the with the Florida Department of Health, the county, and FIU and the Youth Fairgrounds. So we opened yesterday and we had a very good turnout, a very smooth operation. Today was our second day. And within yesterday, we had 264 tests that were being done, and today we had about 270. So that has ran very smoothly. One of the, we have also, as you know, it's hit the news. We have had our 3D printing in the College of Engineering, and we have that in conjunction with our emergency operations lead, which is Bridget Pelaez. She has worked very hard to do the printing of the face shield. As you know, we had some issues with scarcity of some of the products. So we are working very closely with Baptist Health System, with the Miami-Dade Fire and City of Miami Fire. So also our engineering school is working very hard on the 3D printing. What is the frustration when it comes to, actually as a physician, is the issue with testing. We need more testing, but it's not only the testing, but the type of testing. We understand that this virus actually has a approximately a 2-week incubation, but we also understand that we have those asymptomatic carriers that are out there. And if we are to level off and we are to flatten the curve, we need to understand what is the course of this virus, specifically in the asymptomatic. Another thing that was happening is that the public, this came very fast, and the public basically was not aware of the things that they had to do once they were COVID positive, which is the quarantine versus the isolation. A lot of patients just basically said, I'm COVID positive, I'll need to just stay in my house, but then they had the household that was being exposed to the shedding of the virus. So that has been quite, and I know that we're out there with education and a lot more is known now, and the CDC has been excellent. The CDC website has been, up to date and very helpful for the population. But right now our focus is testing the population, using the different types of tests. We would love to see a rapid test. We know there's a rapid test out there. We would love to see an antibody test. We would love to see if we can actually be testing our first responders, because those are the individuals out there that basically face the unknowns. And so we hope that as more and more days go by, that the state of Florida can actually be very proactive in this. And it's not only the swab test, but we will have other tools in the armamentarium to be able to identify and stratify the different patients and where the population lies. The other, as you know, my colleagues, kudos to my colleagues at that front line. We have them here, we're testing, we're all in the front line. And I think that, these are the times that, number one, you see leadership surface. You see those that are basically at that front line and trying to be there to care for a population and really go to the next level to be able to avoid the next COVID epidemic. So this is pretty much what we're doing now. We're very busy. But what it's interesting is that this new normal may be a normal. So we have lessons to learn. We have lessons to learn that, are we doing the right thing on the educational platform? Should we be now looking more on an online, on a virtual learning methodology, where maybe we need to take a look at the bricks and mortar? What are we doing with our clinical model? Should we be modifying, the clinical model? So there are many things that I think that this lessons learned in the new model is going to be very, very important. And I think that the best thing is the lessons learned. And the next step is to be able to flatten the curve and be able to prevent the next, what would be the next COVID epidemic. And also hoping for the vaccine, because it is with the vaccine that we will be able to then have a much better control of the herd immunity and be able to then look at it just as another vaccine that we will be administering during the fall season. So more to come, lessons to learn, and models to adapt. And then finally, it's a societal. Alfred, like you just said, we're a very smoochy society, so to speak. And so we also have to kind of readapt and relearn how we show our affections in society until such time that we are able, to be able to prevent and finally treat this disease. So thank you so much for the opportunity, and I welcome any questions.
Thank you, Anita. We'll get to those questions. I think you're right. I think for me, being Cuban and a very big huggy kisser, I think I can get my head around when I finally see all my friends and colleagues and how not to. But we're going to have to wrestle with it. I think you're right. We'll get to questions in a second. Thank you for that. I think we've got the next speaker is someone who's extremely important to all of us who live in Miami. Frank Rollison is the former manager of North Bay Village, but more importantly today, he's the director of Miami-Dade County's emergency management. Frank, I can't imagine what you're dealing with throughout the county. And then on top of that, what scares me is that you also have to be getting ready for hurricane season after that. Frank, are you back with us?
Hey, Alfred, this is Spencer with the Chamber. Right now, Frank is on the call with Mayor Jimenez.
Okay.
He'll be joining us in a few minutes, so I think we should maybe take a couple questions, and then when he joins, we'll switch to him.
Let me do something real quick before we do that. Thank you, Spencer. I see that the chair of our healthcare committee, who's also putting this roundtable on, Cliff Bauer, is on with us. Cliff, I know you have a few closing remarks to say, but I'm not sure if there's something that you want to add to the conversation at this point.
Thank you, Alfred. First of all, thanks, Dr. O'Don. Thank Matt for participating in this and all those who are in attendance. We certainly are living in a very interesting time, and I know a term that I've heard bantered about in healthcare for at least the last 25 years is paradigm shifts. Well, I can say this, what we're going through right now is the first paradigm shift I know of that is literally on a global basis. And it's not just in healthcare, but it's also in terms of what we're going to see, the economics of it, as well as, and I think even equally important, is the social interaction and distancing that will become a new normal for us as we move forward. It is going to be challenging. We have to remain patient and disciplined in order for us to get a handle on it and allow our excellent healthcare system and scientists that are out there to produce and find vaccines and medicines that will be more effective. But it is a difficult time, and we appreciate everybody's continued interest and, again, their diligence and discipline to just keep isolated, keep social distance, and be careful of as how we do do all of our activities of daily life. And again, our extraordinary appreciation for the dedication of the healthcare providers and throughout our healthcare system, not only at great places like Jackson or FIU, but at my own institution, Miami Jewish Health. We have 400 patients in a nursing home, which unfortunately nursing homes, as we've heard around the country, could become petri dishes for this virus, given the frailty of the people we take care of. So it's everybody having to work together in order to beat this disease and beat this virus and go forward. So again, I appreciate all the work of the chamber in putting together these weekly sessions, as well as the speakers as we move forward. And let's take some questions if there's any questions.
All right, well, let's do that. Thank you for that, Cliff, and you're doing a great job for us at Healthcare. That's one of our most active committees, and we've really done some fantastic things. This roundtable is being one of them. So here we have a question from Juan Marianacci, and he asked, how do we choose who's going to get the coronavirus first, the test first? So I guess, I mean, that's that in one sense, it's like who gets the priority in terms of what's your job, but also, you know, at one point, the related question is, at what point are we going to get to general testing, where that's going to be necessary, as I understand it, for us to be able to get back to work in any kind of communal setting. So I'm going to start with you, Dr. Rowland. Can you address that?
I guess that's me, Alfred.
That's right.
Okay. So, well, right now, as you know, when we started out testing, there were not a lot of tests out there. So basically what we did is we first wanted to be able to have those symptomatic patients, and that's how we started. So the CDC had a specific guidelines of the cough, the fever, the headaches, the malaise, which we all know, with our flu-like symptoms. So that was the first really bash that we had. Now we know that there are asymptomatic carriers out there. So within this asymptomatic carriers, is very important to be able to pick those that are at the front line. And the reason is because if they do not, you know, if they're
I think we've lost the feed on Anita. Can you hear us? There we go. We're back. Go ahead. We lost you for a second.
I'm sorry, that very important would be, can you hear me now?
You can.
Okay. Very important would be to be able to have the antibody test, which then will let us know who are the individuals that are immune. So that is very important. So again, the different types of testing and the options are extremely important to understand what the population has, whether they're active in the disease, whether they're asymptomatic and they've been immune, or whether they're still infectious. So again, it's having that options of the different types of tests that will deliver a different type of outcome, and therefore how we would be able to approach the population.
Let me turn it over to you, Matt.
As far as the availability of testing?
And who gets it? At what point? I mean, is there a shift in the philosophy about, you know, who we have to treat in the different phases of the disease progression?
I always joke that we have 12,800 employees at Jackson, and all of them know more about communication than I do. And now everybody in the community thinks they're an amateur epidemiologist, and I'm sure actual epidemiologists are frustrated by that. My best understanding of it is really on the phase where we are right now, rather than where to go in the future. That availability of testing in the community is still extremely, extremely limited. So we hear frustrations from our own employees, from community leaders. Hey, I have been in close contact with somebody who is positive. I live with somebody who is positive. I've been treating a patient who is positive. Why can't I get tested? And it's not because we don't want to, it's not because we don't want to have the capacity for it. It's not because we don't want to pay for the equipment or for the staffing. There's just a very finite ability of the community. There's only so many tests that can be processed with the equipment that we have, with the volume of reagents that we have. So just like every other community in the country, unfortunately right now, we've had to prioritize, and that prioritization is done by, first of all, who's symptomatic, and second of all, who's at the highest risk. And something that's awkward for people to kind of wrap their brains around, and I want to separate out, Dr. Roldan is speaking very intelligently about where we need to be to get out of this on the back end. I'm talking about where we are right today with the capacity of testing that we have. If your symptoms are mild enough that you don't feel the need to go to an emergency room, knowing that you're positive doesn't really make a difference, because there is no treatment for mild COVID that is any different from treatment for a flu virus or something like that. In fact, even less so, because there's not much evidence yet that Tamiflu or something like that is effective. So what we've been telling people is, if you are symptomatic and it is not moderate to severe, then what you should be doing is self-quarantining, staying away from other people, controlling your fever with whatever medication your doctor recommends. I think it's usually Tylenol, getting a lot of fluids and getting a lot of rest. Knowing that you're positive isn't going to change anything, because whether you're positive for COVID or you're negative for COVID and you just have the flu, that's what you want to be doing, is not infecting other people and isolating yourself until you recover. Now, expanded testing would have been super helpful on the front end, where we could have done a lot more tracking of who was maybe bringing it into the community. And it'll be important on the back end when we're starting to try and get to normalcy. But as we look at where we stand today with the very, very limited capacity of Miami-Dade County as a community to process tests, that's why the focus is where it is.
If I may add, yes, it's important to be able to have that 14-day quarantine. The problem comes in that individuals do not understand that this virus could be shedding beyond 14 days. This virus could be shedding up to 21 days. So the important thing is what we call the re-entry into post-quarantine. And the re-entry to post-quarantine is to be able to, number one, be asymptomatic, but still being asymptomatic, you could still test positive. So after 14 days, you should leave a few days, which would take you into the 21st, into close to the 21st day, from the time you became symptomatic, and then test. It is actually, according to the CDC guidelines, it is asymptomatic with also 2 negative tests after you're out of quarantine that basically will let you know that you're free of a disease. So yes, 2 things. You need to quarantine, because you're right, we do not have a treatment, but you need to quarantine where you are away from anyone, because you are shedding the virus. And the challenge about this virus is that you can shed it up to 21 days. So this is the reason why the educational at the front end is extremely important. You have the virus, you test positive. By the way, it's really isolation rather than quarantine. Quarantine is being used for the close contacts of COVID positive patients. Once you're COVID positive, it is isolation, which is a higher level of really distancing. And then after 14 days, you may be asymptomatic, but you need to test again. And so it really, usually that second test should be beyond 21 days to have 2 negatives. So those are according to CDC guidelines.
That's great. I think you answered one of our questions. What's the difference between isolation and quarantine? I think we got a lot of questions here that have to do with the personal protective equipment. Matt, you said we've got plenty at Jackson and UHealth, but in general throughout Miami-Dade County, what is the availability of it? Is there a real need for certain types? What should we be knowing and doing about that?
So one of the things that I think has been great about this situation, one of the silver linings, is we're seeing a lot of cooperation among people who are normally very competitive. So I know at least my colleagues, all the chief marketing officers of all of the nonprofit health systems in Dade and Broward County have been talking constantly for a month now. You may have seen a story the other day in the paper that when only 2 or 3 hospital systems in South Florida were able to get this new point of care 15-minute test, and neither Memorial nor Jackson were among those. Cleveland Clinic, at the request of Governor DeSantis, sent one down to Jackson. So we're seeing a lot more cooperation on those kinds of things than we have in the past. And that's why I feel comfortable saying that I don't think anybody has a critical PPE issue right now, not from any of the health systems that I've talked to. I think everyone is kind of in the same mode we are, which is to say we have enough for what we need today. We have enough for what we anticipate to need in the coming days and weeks. And what we're trying to concentrate on doing is making sure that within the community, there's enough if there's a spike significantly larger than what the models are currently predicting. So I think everybody can feel confident about where we are. I think some of the anxiety that we've heard in the community, that I've heard from our staff, that I've heard from other hospital systems, is this is not being distributed in the same way that it normally is within the hospitals. So it might normally be that there's a closet filled with N95 respirators, and whenever you need one, you go grab one. Even though we have plenty for where we are today, because we want to be prepared for that worst case scenario down the road, those things are all now being kept at a nurse's station under the supervision of some kind of nursing leader. So people who are accustomed to seeing it in one place and now it's not there, when you layer that on top of the anxiety, the exhaustion, the fear that we talked about earlier, that can really create within an individual this sense that there is scarcity or that there is missing PPE that just isn't the case. And then there are certainly edge cases. Again, 13,000 employees at the health system, 2,200 licensed beds. I am quite certain there have been times where there has been a unit that should have masks at that nursing station that was out of them for a couple of hours while the supply chain was refreshing what needed to be done. That is an edge case, but I'm sure it's happened, and we've been in constant learning mode, just like we're in learning mode on the science side of it. We're in learning mode on the operation side of how to make sure that we're keeping all of this working well.
Right.
Can I add something?
Of course.
So one of the things that we've done at the DCMA is make this PPE equipment available to the physicians, and this is irrespective of institutions, because one of the things that we've heard is that some of the physicians are concerned that they're not able to get adequate supply of personal protective equipment, even those that work for institutions, not just on staff, but actually work for them. And we've been able to get it for them. And so on the medical side, there is the availability to get it. I think there's a lot of people who are not physicians who are very concerned about getting personal protective equipment. And I think that there's a certain sense that they're not protected at all if they don't have personal protective equipment, as if this is some kind of talisman that can ward off this evil infection. So there's two parts of it. One is the healthcare workers, one is the general public. I think the healthcare workers, again, through the DCMA, through some of the other medical associations, you can get personal protective equipment, not just in the hospital.
No. Dr. Roldan, you had to comment?
Well, I think that one of the challenges that we had along the lines of PPE were masks. And there was a lot of either misunderstanding or lack of how you wear the mask and why. So the N95 mask is actually worn by healthcare providers because you need to be fitted and you need to have your adequate size. So you would see, and still I see a lot of individuals that are not healthcare providers and wearing the I-95 mask. So that was extremely important. I think that the fear is what brought this on. So because you could wear a normal surgical mask, which we have a lot more of than an N95. So I think that one of the issues was that. And the N95 is extremely important for the front line. In addition, as you know, now the CDC has changed the guidelines of wearing a mask. But it is important to understand that at the beginning, we used to say you only wear a mask when you're sick. But actually what people were doing is wearing a mask anywhere, which is what we're doing now. So I think that a lot of that was part of what we started seeing, that the numbers were much lower. But I agree with Matt. I think that right now we don't have an issue. But it's very important to understand who wears them, how they wear it, so that we don't run into a situation that we could fall low in numbers and not have the correct individuals wearing the correct PPE.
Yeah, and I think one of the things that I'm seeing on the chat is, there are a lot of companies that are either producers or they're sort of middlemen for these kind of PPEs. And then there's a hospital needs, but then there are other institutions like community health centers, et cetera, that may need them. What do you say in terms of what's the need and how do we connect these people who have the supply with the people who need them?
Well, I mean, we all know that we have the national stockpile, but then we also have private vendors. And I can tell you that since we've had this issue with the pandemic, private vendors are coming from all over the place.
Right.
But I would urge that we also have to be very careful, just like when you heard about the hydroxychloroquine, vendors were coming from all over the place. So it's extremely important that we know who we order from, and there's national supply chains that are out there. So I think it was really the demand, but it would be interesting to see if the demand actually came from healthcare providers, from hospitals, or it came from just individuals that were really, really very, very scared and wanted to use these supplies. That I don't know. Maybe Matt, being at the hospital, may be able to say, but I haven't heard much of any scarcity in PPE here in South Florida. Matt, I don't know if you have anything else to say.
And Matt, also, is there a central distribution? I mean, is there somebody who's sort of a central place that suppliers can go to so that you all don't have to take your time to sift through this?
So the short answer is not really. I do think there have been some attempts and some realities of the state emergency management department, and hopefully we'll be able to hear from Jared in a little bit, being involved with that, and in some cases even trying to route some of the requests through the county's emergency department, and hopefully Frank will know a little bit more about that. But in our experience, this has mostly been, and again, we're working at a much larger scale than a community health center, than an individual physician practice, so it's very different for us. But for us, it's been about leveraging our supply lines. It's been about working with our group purchasing organizations. We don't do a whole lot of purchasing from individual vendors. We work through big wholesalers, and they understand what our needs are. We've always been very responsible about having at least some backup suppliers that are domestic, because we always knew there was the chance of international supply lines getting strained at some points in a situation like this. But I'm not aware of any real major crunches happening in the places where you would need it most. There's also a big, I think, open issue that goes back to something that Dr. Roldan was saying, which is, I don't think even within the healthcare community, at the frontline caregiver level, there's a whole lot of comfort level that they fully understand what the right level of PPE is. So if you, as a receptionist at a physician's office, as a security guard at a hospital, know that you're going to be encountering people who very well may be COVID positive and shedding virus, it's very hard to make peace with the fact that we're saying you should just wear a standard surgical mask, while the nurses who are actually on the unit should be wearing N95 respirators, right? There's a lot of complexity in this. And I also think that communicators, whether it's healthcare professional communicators, whether it's the media, whether it's the public health agencies, accidentally probably did this community a little bit of a disservice at the front end of this when they were saying, don't buy masks, don't wear masks. And they were saying it in part to make sure that the healthcare supply chain was able to keep up, and that was good. And I also think some of the messaging about, well, wearing a mask could be worse, because it makes you touch your face more. And I think there was some very mixed messaging that came out in those early few days. And I'm sure there's a lot of people who would love to have January and February back to change some of the decisions we made. And that applies to communicators as much as it does to the clinicians and supply chain people, and I'm sure the White House. But I think we're catching up, and this is what resilient societies do, and strong communities like Miami, is we don't spend too much time looking in the rearview mirror when we're in the middle of something. We learn new information, we adapt to it, we make the best of it, and then when we get to the other side, we take the time to say, okay, what do we learn from this that we can do better next time?
So, I mean, and I want to get to this whole notion of the philosophical differences between, what they do in Asia, where everybody's wearing a mask, and here we're saying don't wear a mask. And we have recent orders now by the mayor and other counties are saying, hey, if you're going to go out to Publix, you're going to go out to your CVS or Walgreens, you're going to need to wear a mask. Where are we on this? Is it yes, wear a mask? We should always wear a mask. Is it no? And what do all the people do who don't have masks? We'll go with you, Dr. Roldan. Why don't you take that one first?
Sure. Well, first of all, as you know, that we have even come out with educational videos of what we call the homemade mask. And it's basically, when you're out there, because we know this is aerosol and you can have someone very close, which social distancing is important, just to protect yourself, it would be good to protect that area. So it's not that you need an N95 or you even need a surgical mask. You could even have a handkerchief, right? So the idea is that because again, we still have yet to know a lot of how this virus behaves. We do not know if you're in the line with in Publix, and yes, you might be 6 feet, but how many people really is counting? You could get closer to the person, and if that person could be shedding virus, the way to protect yourself would be through having your area where we know is the entry point of the virus covered. So that's where we are right now. Again, therefore, we need a lot more of what is happening in the population. And until we do so, we can't really say things in absolute. So we got to go with what we know. We know that this virus is actually transmitted in the air, right? You could have a person that's talking to you, you can have droplets, and therefore the best way for us to tell you to protect yourself is to cover that area. So, but once we have a vaccine, once we have what we need to do, we're not going to have that in another 12 or 18 months. Until such time, we just have to go by the different steps of what we know now of the virus. So I will tell you, this is very interesting. I always said as a physician, it is really the person that is sick that should wear the mask. But even before we even went out and said everyone should wear a mask now in public, I used to tell individuals that would ask me, if I'm on an airplane, if I'm on an airplane, do I wear a mask? I said, in an airplane, you're very close to individuals. If you're there in the economy, you've got 3 people and you all packed. Well, not everyone, as we know, will cover when they sneeze. Not everyone, will do the right thing. So I used to say even then, wear a mask because you have to protect yourself. You cannot be, dependent on the other person protecting themselves. So it's just a good custom.
Let me interrupt. Matt, it looked like you had something to say, but why don't you hold the thought for 1 second? Because I think I see that Director Moskowitz is on the line. Director, are you on with us? Perhaps he was just getting set up. All right, Matt,
He's getting set up, Alfred, but we will let you know.
Okay, go ahead, Matt. You wanted to take a stab at the whole question about whether or not we should be wearing masks or not. I mean, no.
I have nothing to add to what Dr. Roldan said that is either relevant or true.
Okay. So there's a question, Dr. Roldan, that you mentioned that there might be a 21-day period for the virus shed, and folks are saying, hey, could you share some specific information on that, because they're not finding that in any of the CDC guidance.
Well, actually, we know that because we have had individuals that have COVID positive, and we know that, by the way, in studies that come from China. The original studies from Wuhan and other studies from France, which means that they have tested individuals after the 14 days and they have found that they're still positive. So again, what we know is that the incubation period could be 2 to 14 days, but there is literature that says it could be up to 21 days. So it all depends how that virus is behaving. So this is the reason why when you go to the CDC website, which is basically what's called the disposition of the patient, which is what to do once you're positive, it will give you a guideline of when you have to do testing, well beyond when you're asymptomatic, and so on and so forth. But we know that from studies that have shown that you could be shedding virus up to 21 days.
Okay, thank you for that. I see that we have Frank Rawlson, who's Miami-Dade County's Emergency Management Director. Frank, welcome. I know that you've been hopping in and out of calls with the mayor and others. We can only imagine what you all must be going through with, not only, as I was saying earlier, what I thought you were on, is not only dealing with this, but we're going into hurricane season. So I wanted to give you a chance to tell us a little bit about where we are on this epidemic and how emergency management is dealing with this and preparing for the future.
Well, good afternoon to everybody. Yeah, we've been hopping, to say the least. So I did get bumped up on the call with the mayor. So fortunately, they were able to schedule me so I could get out, because those calls go on every day and they're usually a couple hours long. But we bounce stuff back and forth. But anyway, it's good to be here, and thank you for inviting me to participate in this. I'll give you just a little brief update where we are at the Emergency Operations Center for the county, just dealing with COVID at the moment. There's two primary things that we're doing here since we've really been up. The one is making sure that the seniors are fed throughout Dade County. And we are delivering daily home delivery, over 30,000 meals a day to seniors, that since the senior centers and the different centers have been shut down throughout the county to try to get the social distancing, these people are shut in at home. And so that's a big project, and it's a gigantic project to coordinate and be able to come up with the vendors and the delivery process and all that. So that's one of the major things we're doing. And the other issue that we're very much involved in is trying to obtain personal protection equipment, the PPE that you're everybody talking about, because it's hard to come by, and we're supplying throughout the county. The hospitals get PPEs from us. Everybody's scrambling wherever they can, and that's part of the problem. There's really no centralized process throughout the country for this stuff. So the states are fighting for it, and then the counties are fighting for it, and municipalities are fighting for it, and all the hospitals and the nursing homes and the ALFs, they're all trying to get it. So it's a seller's market, and we're certainly feeling the brunt of that at this time with the exorbitant prices that are being placed before us. It's unfortunate that it's turned to this, but that's the nature of commerce, I guess. But we have a tough time getting it. But what we do get, we're on a 24-hour operation here. Some of you may have seen the little bit that was on Channel 7 last night. They came out and interviewed us. And so we've got a process here. We've got a warehouse. We have through Web EOC, which we encourage more and more people to get on that program, because that's how all of the emergency management operations in the state operate. Once we go into mode and the state goes into operation, we're all on Web EOC. And all the orders, all the exchange of information, all of the requests for missions, regardless of what it is. You need a USAR team, or you need a dive team, or you need a bulldozer. It all goes through Web EOC. And so we have to spend a lot of time converting emails from people that have not really provided the sufficient information for us to make the requests that they need for them. So it's a learning curve for everybody. And of course, this is a totally different animal for us this time. But when you talk about emergency management in South Florida, or in Florida in general, everybody thinks about hurricanes. And I can tell you, before this COVID event, we spend more time planning for complex coordinated terrorist attacks than we do for hurricanes. There's also biological attacks that we plan for. And when you really look at the COVID event that we're in,
That's for you.
We're in that kind of event right now. That event that we're going through is much the same as somebody had released that agent into the air, and we were having to deal with it.
Yeah, this is way better.
We approach it from that standpoint, and we deal with it that way. And I think the mayor in Dade County has been a leader in a lot of the things that are happening throughout the state, with a lot of the actions that he has taken. And hopefully this safer at home and the distancing is going to be a positive impact on us for all of the state of Florida, and hopefully in Miami-Dade County. But that's, that's what we're dealing with right now. I don't want to take up a lot of time, and I know there's going to be questions at the end, so I'll just.
Well, thank you for joining and thank you for that thorough review. And speaking of the state's reaction, we have Director Moskowitz. Jared Moskowitz is not only the director since January. Well, you sure know how to pick good timing, Director. But he's also been state representative from Coral Springs and was very involved in the legislation that came out of the massacre there. So we've got someone who cares deeply about the community. Director, I want to give you a chance to talk about what's going on in the state currently, what's the projection for the future, and what's your best guess at what the new normal is going to be and when is it going to be here?
Sure. So first of all, thank you for the opportunity, Frank. Good to see you. Appreciate everything you're doing down in Miami-Dade. So it's been a pleasure to be working with Frank. So here's where the division stands out. Let me give you some of the top lines because I think that's important. So today alone, just for today, we're going to be pushing out 2 million masks, 300,000 face shields, 50,000 containers of hand sanitizer, 500,000 shoe covers, 100,000 gowns, and 350,000 gloves, which will take our total to 5.2 million masks, 500,000 face shields, almost 5 million gloves, and 275,000 gowns. And so we're doing that with a 24/7 operation out of our warehouse in Orlando. We've partnered with the Army Corps of Engineers over there, our 200,000 square foot warehouse, getting this stuff out all night, all day. We're delivering goods via 18-wheeler, via van, via air by chartered aircraft that we've arranged for, first time ever that the division has ever done that. And we're working obviously with our counties, our emergency management directors at their county staging areas, and we're making sure that this is getting to the front lines at our hospitals, our nursing homes, and our first responders obviously on the street, our police, fire, and everyone else that's been involved. As far as the big stuff that we're working on, obviously the governor and I were in Miami just yesterday announcing the convention center that we've partnered with the Army Corps of Engineers, which will be a 400-bed hospital facility plus 50 ICU beds there, and that will be online by April 20th. We are also working with private vendors approved by FEMA and HHS to bring back a 200-bed hospital back online in Miami-Dade, and on April 10th, the 250-person field hospital at the fairgrounds will open up to be able to accept people. These are all COVID facilities. These are all acute COVID with the ability to have a step down to an ICU in the event somebody immediately changed their status, degraded on us while they were at any of these facilities. At the moment, the IHME model seems to be trending more favorable. We are ahead, I would say, based on the amount of beds we have available versus what the IHME model said we would be as of today. The ICU beds are tracking pretty close. We are well ahead on ventilators at the moment on capacity than where the IHME model said we would be. And so, look, that model's trending better for us. You can see it kind of in the graphs. Hospitalizations are pretty stagnant. Dade County still has a higher hospitalization rate and higher positive rate than everywhere else, but that's not because Miami-Dade hasn't done a great job. They've done a fantastic job. The mayor's done a fantastic job there. It's just Miami-Dade, just like New York and Chicago and Detroit and LA and all of these other urban centers where populations are on top of each other, is unfortunately, the incubator for COVID-19. And so we're continuing to focus on Miami-Dade. We moved 100 ventilators into Miami-Dade today. They're pre-positioned there just in case. And that is already in addition to the 30 ventilators that we had pushed down into Dade County just last week. We partnered with the Department of Education. Commissioner Richard Corcoran did a fantastic job, and we were able to locate 120 ventilators at our colleges and universities. And so we are actually going and gathering those up now, and we will pre-position those around the state. So 120 ventilators sitting at our educational institutions being donated for free, that in the event we need them, obviously we will put them to good use. And so, we are still leaving no stone unturned. I know obviously people are breathing some sigh of relief, but I would warn people that, look, we're not near the peak yet. We got to get through next week. We got to turn that corner. Dramatic focus on PPE. As many of you know, I've been very vocal about the PPE shortages around the country, not just here in Florida. We're doing better in some categories than others. And so people just need to be vigilant. They need to continue to social distance. It's extremely important as we get into the Easter holiday that even though we want to make sure our religious institutions are essential businesses, there should be no mass gatherings of any kind per CDC guidelines. And so, as the governor said, we want people to keep God close and COVID away. And so we're hoping as we get into the weekend that people will find other ways to have a joyous Easter holiday. I want to make two more points. One on this IHME model. Originally it said we were going to peak on May 4th. Now it says we're going to peak on April 20th. And so, we lose 12 days. To give people perspective, we only had 11 days to prepare for all of Dorian. And so 12-day loss is a huge loss for all of these emergency management directors around the state, as well as myself. But that comes also with some good news in that our numbers are looking less than the model originally predicted. I bring that up only because it just goes to show you how unpredictable this situation is. And it's very possible we could wake up tomorrow and the model could change again. And that's why I want people to be vigilant. Think about a hurricane. We have all these different spaghetti models of where the hurricane could go, all different scenarios. Usually it's a vast, wide area between staying in the Atlantic and winding up in the Gulf of Mexico. This is no different. There are all sorts of different variables, all sorts of different scenarios. And lastly, to answer your question as far as, where do we go from here? What does it look like to getting back to normal? I mean, listen, that's a fun philosophical conversation to discuss, but here right now, the division, we're not focusing on what will it be like to get back to normal. I still have a lot of very sick people around the state. We had the highest death rate in one day yesterday. We're going to continue to trend upwards. As we know, the deaths unfortunately lag the ICU hospitalizations when it comes to COVID-19. And so it's premature for us to pretend like we're moving on as many families are suffering around the state. And so, in a couple of weeks, we can have those conversations. We'll look forward to CDC guidance. Dr. Fauci has been very clear that going back to normal, it'll be some sort of new normal. It won't be what we were used to, at least, not in the beginning, not until we have a good therapeutic, not until we have rapid testing, and not until clearly we have a vaccine. So we're running 24-hour operations here. We're at a level 1. I anticipate we'll be doing that for quite some time.
Well, thank you for that. And I think you've definitely echoed what Dr. Roldan was saying earlier as well in terms of how do you get back. There's a lot of questions in the chat having to do with, and we've heard from Matt and others that our hospitals are okay for now in terms of supply, but a lot of smaller private practices, clinics, and others are saying, hey, they don't have the supplies, or the suppliers that they can get from are asking for huge numbers of purchases in order to get access. How can they get access to those so they can sort of practice, have safe practices?
Right. Well, I would tell them to get in touch with their county emergency management director. Obviously, if the county emergency management director believes that that's a mission that needs to be fulfilled, they can put in a mission request. Obviously, we're prioritizing people, on the front lines at our hospitals, our doctors, our nurses, our physician assistants, our techs that are working all of these things. And so, our first responders, police, fire, paramedics. And so obviously we want to make sure that we're taking care of our small clinics, our small doctors. We've been sending a ton of stuff to nursing homes and ALFs because that's extremely important. Secretary Mayhew obviously put out guidance that we want to make sure that those folks are wearing surgical masks. But I would route that through their county emergency management director, let that county emergency management director like Frank Rawlson make that call on available resources. I mean, I understand what's going on in the supply chain. I understand that people are requiring large orders. I understand that they're requiring money up front, which nobody is comfortable doing, especially in the market that, I've talked about kind of what's going on out there, as the other states have all echoed. And so I get it. We're all in the PPE fight together, but I'll do what I can to assist.
We appreciate that. And for those who have that question, we'll do some research and try to put it up on our website if we find something. So thank you for that. Are there other questions for the director? I know you have limited time, Director, so I want to make sure that we get the targeted questions to you. One from former legislators, Elaine Bloom says, why don't healthcare workers get rapid test results so they can return to work immediately if negative, or just faster if they are sick?
No, it's a great question from Elaine. Elaine, I hope you're doing well. So here's the answer to that. So the governor early on called the president to make sure that the state of Florida was included in the Abbott Laboratories rapid test. The governor was successful at that. Abbott Laboratories chose 10 hospitals around the state and sent a number of machines to those hospitals, as well as 1,900 rapid tests to those locations that are being replenished on a weekly basis. And so those hospitals are doing rapid testing of all of their employees, and now doing some rapid testing of people coming to those facilities. Additionally, we were able to secure, with the help of HHS and FEMA, 20 additional Abbott rapid machines, and we are receiving weekly cartridges, 120 cartridges per machine on a weekly basis. So we're going to be deploying those out to a number of hospitals that didn't receive them directly from Abbott Laboratories. I can tell you the governor is extremely focused, continues to talk to the White House almost on a daily, every other day basis about the Abbott laboratory test and the rapid testing. That seems to be the most reliable rapid test out right now. 5 minutes for a positive, 13 minutes for a negative. You can walk in at 11:45 and by noon, know whether or not you're positive or negative. I mean, that's a dramatic difference. It's the future of this testing, no different than a strep throat test or when you go in to test for the flu.
Thank you for that. We've got a bunch of questions that have to do with hydroxychloroquine and the malaria drug, and where we stand with the use of that. And I want to open it up to Dr. Roldan and Matt, and Director, certainly you can weigh in on this. There's a lot of questions about is this something we should be moving to? What are the downsides of it, et cetera?
Yeah, I mean, I'll let the doctor talk about the medical aspect because the division's not going to weigh in on that. So what we've done is we've helped give the hospitals the resources to make those decisions. And so we were able to get donations from 2 pharmaceutical companies, over 1 million hydroxychloroquine pills, as well as Z-Packs to go along with them. We've made them available directly shipped to them, and also made them available through the state pharmacy. We have no recommendation, we have no guidance on that coming from the state. We're leaving it up to hospitals and doctors and medical practitioners at the local levels to make those decisions.
Dr. Roldan? Thank you, Dr.
Yes, well, with the hydroxychloroquine and the Z-Pack, one of the things that is extremely important is, first and foremost, that they have to be used under a doctor's direction, because we know that in any type of crisis, there are a lot of websites that come up, and you have individuals out there that feel that this is used in prevention. That is not the case. So that's the first thing. The second thing is that it's extremely important that the dosages are to be followed. There's certain dosages of the hydroxychloroquine. The Z-Pack is easy because we've all been at one point or another, we've all used the Z-Pack. But it's extremely important, the dosaging of the hydroxychloroquine, because we know that there are some cardiac effects. So if it's not used properly, then the patient will have some side effects. So that's one of the things that's important. Now, as we know in the research scientific world, one of the things that we say is that we wish we would have more time, right, to be able to use that combination of medication in a greater population, so that we can effectually say, well, these are the patients that would be able to react, these are the patients that are not able to react. But because we are in a situation that we are, and there's still a lot of unknowns, and we know for a fact that we have patients that have done very, very well, done under the observation of a doctor. That's where we are right now. But it's very important for everyone out there to understand that it needs to be done, and you need to follow your doctors under doctor's orders, not just going on a website and buying hydroxychloroquine.
Thank you. One of our members, and because I think this whole notion of, or this is unprecedented. No one's ever seen this before. Can't we throw new procedures, new treatments at it? One of the members asked about some therapies using ozone that had been proven effective with SARS and Ebola. And I don't know if any
Yes, sir.
you have any thoughts about that.
I will defer. we do not have, currently, we do not have any scientific basis for that. We have to understand that although coronavirus is a type, if it's from the same family, let's say, of the other coronavirus, that we know they're different. You know, it's just like being in a family and you have two different individuals. So we do not have, at the current time, we do not have any scientific proof for that.
Thank you for that. Frank, did you have anything else to add on that, on what's going on in the county? I know I cut you off when the director came on.
No, listen, I'm used to the process.
Great, thank you. I appreciate that. I think now, I guess, one of the questions that have come up is, what about these fake testing sites? How do you know what's going on? How can you tell if there's a fake testing sign? And maybe, Matt, I know you guys do a lot of testing over at UHealth in Jackson. Any advice you can give our members about that?
I mean, the sites that we have in the county, we advertise out that we have recognized that are taking place, and we put out a sit-rep report every day that goes to all the municipalities throughout the county that they can put out within their communities, however they decide to use that information. But the primary sites that we have going now that we are aware of that are not private sites, and I know that at one of the private sites, there were a whole series of tests that were not done properly, and the people had to be retested, and then the site folded and they couldn't redo it. And they're in a bigger quandary now than they were before they went to get tested. So it's, we're finding the same things with PPE. I sit here at my computer and go through all of these vendors that come in, and they've got 1 million of these and 1 million of that and all that. And we vet every one of those pieces of PPE. We have them supply copies to us, give us the product so we can test it. And most of it, unfortunately, we're finding now fails and is knockoffs or something of that sort. Even to the fact that some of them have gone so far as to mimic the seal that's on the front of the 985 mask, the NIOSH seal, and they stamp that on there, and you have to look at it like with a microscope or a magnifying glass to see if it's so it's the nature of the beast. But if somebody's got 1 million or 2 million of these things out there, why are they having such a tough time getting rid of them? Everybody wants them. So you're suspect to begin with when they call you, and it's like selling us a bridge,
Yeah, exactly.
Alfred, if I could weigh in for a second. I really appreciate both Frank as well as Jared's comments about the fact that this PPE supply issue, there are, big institutions like Jackson have access to huge numbers. They buy in huge numbers, but you get down to the areas that, such as doctors' offices, nursing homes, et cetera, and it's vital that those people get their supplies, because if they're effective in getting PPE supplies, they're more likely to help keep those patients, the people at home who are tested positive, or they're concerned, or they're not healthy, or the people that are already in a nursing home out of the hospital, and therefore not stressing the hospital to a degree like you've seen up in the northeast part of the country. So I hope that both Director Rollison as well as Director Moskowitz made a great point about the fact that access to PPE supplies it's easier for some, and it's a tremendous effort, a Herculean task for many smaller organizations, not only in terms of finding somebody who has something. Ours, Frank just said, we got 1 million of them. Well, what are they? Well, they turned to be knockoffs, and they're not as accurate. They're not really the real deal. But also the other side of it is the cost. I mean, we're paying 5-6 times what we paid for a surgical gown or an isolation gown or a mask or something. And okay, but it's we're not a huge organization, Miami Jewish, but we're bigger than most. But you get smaller than that, and people can't afford it. And particularly if you're a small individual physician practice or group practice or a smaller nursing home, so it's a real challenge. But it's important that these people, and both the County Emergency Management Department, the Department of Health, and the state's emergency management people have helped us in getting supplies to us and others throughout the county, and we very much appreciate it, and their efforts are continued. And we're anxious to see the results of what Director Moskowitz spoke about earlier in terms of just shipping out today the huge quantity of PPE and various types throughout the state. Thank you.
Thank you, Cliff. We're coming close to the end. I've got one last question. I want to direct it to you, Matt. This is a question from Fraser Kobe. Isolation orders have greatly expanded the use of telehealth for patients throughout the healthcare system. Do you feel this expansion of telehealth will be permanent as part of the care design in the future?
Yes.
Thank you for that, Matt.
I think a lot of us have been talking about doing more with telemedicine for a long time, and I can't count the number of chamber panels that I've sat in about that. And I think, there's nothing like a crisis to force you to try something new. So I think a lot of things that people were hesitant to try, either because of regulation, because of reimbursement, because of technology, a lot of those either went away as part of the emergency orders, or people became much more willing to take some risk and try things. So I don't think that 6 months from now we'll necessarily be doing as much as we're doing today, but I think we'll be doing a lot more than we were 6 months ago. And I think one of the silver linings of this is that we're going to have a live fire test about where are the problems, where are the rubs in all of those different areas, right? What parts of the technology work well for the provider and for the patient? What are the reimbursement concerns when you have conversations between payers and providers and patients? Does it end up being a comfortable and secure environment to have those kinds of conversations? I think there's a reason why you saw it proliferate much, much more with very simple incidental primary care, like, take a look at my throat, does it look like I have strep? And behavioral health, where you could do talk therapy, you don't require any kind of clinical interaction. And even dermatology in some cases, people were much less comfortable doing it for other kinds of subspecialty care. Now those hands have been forced. So let's see 6 months from now, a new mom who is maybe in her last trimester right now, who, if she's having a routine pregnancy, is maybe having her weekly OB appointments in some component through telemedicine. What are we going to learn from that we can apply in the future?
I think that's great. I mean, I think the reimbursement part is the big thing. I mean, necessity is a real mother, and I think having Medicare patients who can't have hands-on right now, but they still need to get paid. I think that's a big issue. Dr. Roldan, I'll give you the closing.
Yes, absolutely. I think definitely is the reimbursement issue, but also the type of platform that is being used. As we know that now with the situation that we have, there's been some relaxing guidelines as to which platform we can use. And I think, again, it takes, like Matt says, it takes a crisis to kind of get us to say, why not, right? So I agree. I think that telehealth, telemedicine is here to stay. There is definitely a way of stratifying the type of patient that will be able to engage better. But definitely this is something that hopefully once COVID is out, and it will be out, that we continue to really look not only on the reimbursement, the usage, the end uses, but also the platform.
Well, and another really important point about that is what enables the platform technology. right? So how many heart patients and their doctors, their cardiologists, are going to be comfortable with some of these devices that strap onto your phone that can very, very accurately do some of what an EKG machine can do? How much better are even at-home digital thermometers and things like that, digital blood pressure machines, going to get, so that a physician feels comfortable that that is a reliable source of data and can pipe it in directly? Because some of what exists at the consumer level right now may be okay for seeing if my 10-year-old is running a fever, but may not be a really good way for an internal medicine doctor to manage somebody's chronic condition.
Well, thank you. We're just
I'd
about out
like
of
to.
time. Oh, go ahead, Dr. Bessie, go ahead. I'll give you that.
So there's two quick points that I wanted to make about this that has happened in telemedicine. We've adopted quite a bit of our practice, and again, I'm in the largest neurology group in the country. To telehealth, two big important lessons. Number one, not just the reimbursement, which is very important, but also the overwhelming amount of regulation has been very destructive of innovation in healthcare, including in telehealth. And the removal of these regulatory restrictions has really been very helpful, not only in helping expand telehealth, but actually in several other things in response to this in response to this crisis. And I think that point of deregulation in healthcare is really important, because it is really killing people. It is not helping at all, and the telehealth experience shows that. The other part is there is a lot more innovation in telehealth to make it more effective, including better use of people with the technology. There's a whole research component to it that the universities can play a huge role in doing, particularly places like FIU, that the engineering department coupled with the School of Medicine can do fantastic things. I actually know people on the faculty at FIU who are working on those projects, and there are many good things coming, but the regulatory environment has to change.
Yeah, thank you, Dr. Mesa. And also want to thank Dade County Medical Association for your sponsorship of this event. I hope it was useful and enlightening. I certainly found it to be so. I want to thank everybody for being a part of this. This is going to be a regular feature on Thursdays from 1 to 3, and I mean to 1 to 2:30. And really want to make sure that people tune in. We're going to have relative and relevant programming throughout the year. I think next week we have education coming up. Cliff, I'm going to turn it over to you as the chair of the Healthcare Committee to do our closing. You're on mute, Cliff.
Thank you, Alfred, and thanks to all the people who participated. I'll close by saying, be diligent, stay safe, and keep healthy. Happy Holy Days to all.
Thank you, and thank you to all our panelists. We really appreciate the time you've taken. I think it's extremely valuable information. Thanks again. Stay happy, stay safe, and stay healthy.